Welcome, everyone. This is Kate O'Malley from the California Healthcare Foundation. We're so pleased you've joined us today for actually the inaugural voyage of the Palliative Care Measure Menu. You may know the California Healthcare Foundation has been interested in supporting the development of palliative care programs, both inpatient and outpatient, for many years. And one of the key issues that accompanies this journey is how do we really know what we're doing is making a difference, and how can we use the scarce time of our very talented and overworked palliative care providers to actually collect and display relevant data that helps to prove the case in our developing field. So we've had lots of very talented people in the state working with us on these issues over the years, and I'm very pleased today to have Kathleen Kerr on the line with us to really walk through a palliative care measure menu that we hope will really help harness and focus your efforts, make the best use of your time, and really come up with very convincing ways to prove the value of your work in the healthcare system in general, to your fellow providers, and most importantly, to the people and the families that you serve. So with that, turn it over to Kathleen. And just from a logistical standpoint, at this point, all the lines that are muted, everyone who's signed on, your line is muted, but we will have time at the end of the call in our Q&A function on the webinar for you to ask your questions as part of the presentation. So thanks again for joining, and with that, I'll turn it over to Kathleen.
Hey, thanks, Kate, and thanks everybody for taking an hour today to listen in. I have a lot of ground to cover. First of all, disclosures. I have none that are relevant to this talk. And objectives for our time together. I'm going to spend a little time talking about measurement generally, and we'll do that by reviewing a 5-step process for selecting a balanced portfolio of feasible measures for your palliative care program. Then I'll go over a framework that Brian Cassel and I have developed for determining how many and which types of metrics your service might track. And then we'll get to the fun part that I'm really excited about, which is reviewing a web-based tool, the Palliative Care Measure Menu, that we think can really help you to identify and select metrics that are right for your program. So measurement goals, what is it that we're trying to do when we undertake the task of measuring for palliative care? This can seem more complicated than it is really. And simply put, I'd say that the goals of measurement in palliative care is being able to describe your program, what it does, and its impact on outcomes of interest. And you'd be doing that describing to the readers, excuse me, decision makers and other stakeholders. And this is really true whether or not you're looking at specialty palliative care or the effects of primary palliative care, all that effort that you're putting into educating your colleagues. And we've nailed this down to a 5-step process, and then we'll spend a little time talking about all of these. First, you'd begin by reviewing best practices in the palliative care field. Then you'd elicit and appreciate stakeholder priorities, identify potential structure, process, and outcome metrics, assess feasibility, so that's considering data collection burden and data accessibility issues, and then you'd pick your portfolio of feasible measures. So starting with best practices. Really, a really good way to go about this task is to consider the National Consensus Project for Quality Palliative Care's clinical practice guidelines for quality palliative care. This is a, excuse me, I'm aspirating here. Okay, that's better. This document's in its 3rd edition. It was developed by a really exquisite multidisciplinary expert panel. It's firmly anchored in the evidence. And what it does is it describes best practices in palliative care according to 8 domains. So structures and processes of care, physical aspects of care, psychological and psychiatric aspects of care, social aspects of care, spiritual, religious, and existential aspects of care, cultural aspects of care, care of the patient at the end of life, and ethical and legal aspects of care. And really, these core components are what make palliative care different from geriatrics and complex case management and good family medicine. This is really what our services are all about. And by looking at a document like this that identifies best practices, you can really begin to understand what you're trying to achieve and then the structures and processes that you need to have in place to achieve those ends. There's 27 guidelines within this document, 140 separate criteria, and any of you who have not reviewed it, I really recommend it to you. It's a long document, about 70 pages, so it's not a quick read, but it has a lot of very valuable information in it. Once you get clear on best practices, the next step that you want to take as you're developing your metrics portfolio is eliciting stakeholder priorities. And here's a list of common stakeholders. You have patients and families, of course, health system leadership, payers are important stakeholders, donors and foundations, referring providers in your team. And all of these folks will have a particular perspective on what they think is important about palliative care. And you should keep that in mind, and also any of their articulated data needs as you're developing your metrics portfolio. So how do you know what they care about? Well, there's a couple ways. You ask, you get told, and that's often what happens if you're part of the health system. And you can also find out by looking at palliative care articles. So there's literature that speaks to the types of issues that are important, for example, to patients and families. Once you get clear on stakeholder priorities, then you need to go about the task of identifying potential metrics. And here it's useful to think about the Donabedian model, which really defines quality in terms of outcomes. And outcomes are a result of what you have in place, which is your structures, and then what you do, which is your processes, and that leads to your outcomes. So structures in this sense, in this way of defining quality, and that's the context of healthcare. That's the facilities, personnel, organizational characteristics, payment models, the things that are in place. Processes are actions, including those of patients and families, so that's what happens. And when you combine structures and processes, that leads to outcomes. And outcomes are defined as effects on health status, quality of life, knowledge, behavior, satisfaction, et cetera. So structures are what's in place, processes is what gets done, and outcomes is how it all turns out. And you're going to want to have metrics that speak to each of these three areas. So how does that apply to palliative care? So here's some examples, palliative care program structural metrics. So again, these are what you have in place to serve patients and families, things like team composition, training, availability, the payment mechanisms and organizational characteristics. Examples of those as they would pertain to palliative care are how is your program staffed and how are those staff trained? What are the services that you offer? And what are the locations and settings and availability of your team? So those are all examples of structural metrics for palliative care. The next type of metrics, process, palliative care program process metrics. And these are really best described by these sorts of journalistic questions. So who, what, where, when, why, and how much. So what were the characteristics of the patients that were seen? What did the palliative care team do? Where were the services provided? When were the services provided? Why were they provided? And what was the dose of palliative care that was offered? So some sample process metrics for palliative care, the volume and characteristics of those approached or seen, which issues were addressed, where did this take place, the time of the first contact with the palliative care team relative to diagnosis or death, proportion of patients receiving a comprehensive assessment. All of those are examples of process metrics that you can use in palliative care. Next up are outcomes. And for palliative care, it's really useful to think of outcomes in three groups, and then to also recognize that there's a cascading effect. So the primary impact of your palliative care program would be on patients. And what you'd be looking to do by way of outcomes is preventing and relieving pain and other symptoms, attending to social, emotional, spiritual, practical needs, clarifying prognosis and goals of care, assuring that there's concordance between preferences and the settings and types of services delivered. So your primary impact, your outcome of one set of outcomes, your first set of outcomes, will address the impact of your palliative care program on the patient. And if you're successfully able to influence outcomes for the patient, then you would have a secondary impact on those around the patient, so social outcomes. The impact that the palliative care team would have on the family, so they would be less confused, more satisfied. They'd cope better, and therefore they could help the patient more. You'd also have an impact on nurses and doctors, those around the patient that are providing care, and they would appreciate the service, so they would be satisfied, and they would be experiencing less distress about the type of care that's being delivered to the patients who they may not be able to help using their normal processes. And so if you have a primary impact on the patient, you have those outcomes taking place. You have a secondary impact on those around the patient. Then the third level of outcomes for palliative care, which can really only take hold if the first and the second level are achieved successfully, is the impact on institutions and systems and payers. So here is where we would see the impact on fiscal and operational outcomes. So if you're able to take better care of the patient, if you're able to assure those around the patient, then and only then you would see an impact on the frequency and intensity and duration and setting and costs and revenues for services, and impact on quality and performance metrics that have to do with service delivery. So three types of outcomes that you're able to address with palliative care. So what do those look like? So here's some sample clinical and patient-reported outcomes, and these would address things like control of pain and other symptoms, improving or stabilizing functional status, improving or maintaining quality of life. Sample social outcomes, so family satisfaction with health care, decreasing family members' depression, anxiety, and distress, and then also avoiding super bad bereavement and debilitation, not to be confused with super duper bad bereavement and debilitation. And then finally, your sample cost and utilization outcomes, so those that impact institutions. So these would be things like more than 2 ED visits in the last 30 days of life, whether patients are receiving any hospice at all, much less the hospice length of service, and then also things like cost of hospital care in the last 6 months of life. So 3 different types of outcomes that are pertinent to palliative care. So where do you find these metrics? Where would you find structure and process and outcome metrics that would be appropriate for your palliative care service? Well, we actually have an embarrassment of metric riches in the palliative care field. There are lots and lots of examples of metrics that are being used to assess the quality of palliative care. And 3 common sources would be professional organizations, the literature, and case studies. And let's talk about a few of those in a little bit of detail. So one professional organization that has released metrics that are appropriate to palliative care is the National Quality Forum. I'm sure many of you are familiar with this group. It's a nonprofit, nonpartisan public service organization, and they're really in the business of reviewing and endorsing and recommending standardized healthcare performance measures. The National Quality Forum uses an incredibly rigorous process for vetting potential metrics for any given area of healthcare. They have expert committees made up of varied stakeholders, and you see NQF endorsed measures in use in a wide range of settings. The federal government and many private sector entities use NQF endorsed measures in payment and public reporting programs. And so all things being equal, if there's an NQF measure that's appropriate for your palliative care service, you should really consider using it because it's going to carry a lot of weight with a lot of folks. As of today, as of 2015, there are 20 measures that address cancer end-of-life care and palliative care generally that have been NQF endorsed. Another notable source of endorsement of measures that are used in palliative care are those that were identified and recommended by the Measuring What Matters initiative. So it's an effort that was jointly sponsored by the American Academy of Hospice and Palliative Medicine and the Hospice and Palliative Nurses Association. They worked on this for some time, I think about 18 months, and they put together a couple expert panels, one that focused on scientific issues, so issues of validity, another that focused on the clinical user panel that really focused on feasibility and importance. And their goal was to come up with a set of metrics that would be appropriate for any patient receiving palliative care in any setting. And their goal was to identify at least one metric that addressed each of the 8 domains as defined by the NCP, and then to publish those, put those out there so that most groups, if not all groups, would use them, and then develop our ability to do some benchmarking and better appreciation of the types of outcomes that would be expected for a palliative care service offered in any type of setting. I'm giving you the URL to the website that describes this effort. There's also a link to a paper that was published in the Journal of Pain and Symptom Management that describes their process and the 10 measures that they recommended. There's actually 9 sort of metrics and 1 satisfaction tool, or 3 possible satisfaction tools. They didn't quite get to the level of finding 1 metric for each of the 8 domains. There were 3 domains for which they did not agree upon a metric: social aspects of care, cultural aspects of care, social aspects of care, and care of the patient towards the end of life. But the ones that they did endorse, if you have a look at those, if they're appropriate for your program and you have the capacity to measure them, all other things being equal, you should use them, because it's a good bet that other people will be using them as well. Another source for metrics is the literature in palliative care, and there are, of course, entire journals that are devoted to palliative care, many of which describe program outcomes and program structures and processes. So there's quite a bit that's out there that describes not only the type of palliative care that's being offered, but how people are monitoring the quality of their services. There's 2 comprehensive review articles that have come out recently. This is one by Drew. It came out of the Netherlands. It's published in the Journal of Pain and Symptom Management. And this group went through and looked at all of the metrics, all of the measure sets that had been put forth over the past couple of decades and used to assess quality in palliative care. They identified 326 indicators addressing the 8 core domains of palliative care as defined by the NCP, and there's an appendix attached to this article, Appendix 3, which lists the 326 quality indicators, and they offer some information about numerator and denominator and performance standard. And I've included the first 3 rows there, and you just picture 323 more rows below that. It's a very useful document, but it's a little bit cumbersome to work through. There's another review article, a terrific piece that was done by Arif Kamal. That one is focused on metrics that are appropriate for palliative care and cancer population specifically, but these are useful resources even if they're a bit cumbersome to access, just because they're static and paper documents, and they're also quite long. So once you've had a chance to think about best practices in palliative care, think about your stakeholder priorities, review the metrics that are out there that are available that you might use for your palliative care service. And let's say you've identified some that are potentially useful to you, ones that are of interest to you and interest to your stakeholders. Your next step is to assess feasibility. And there's really 2 big questions here: burden and accessibility. Let's talk about burden first. So as you consider a metric, as you think about, is this right for my program, you really need to think about who bears the burden for gathering the data that's needed that you'll need to use, and then also for analyzing that data. How hard is it to implement a metric of interest? So let's look at a couple examples of that. The first one here, proportion of nurses, social workers, and chaplains serving on the palliative care team who are certified in palliative care. So this is a structure metric for palliative care. It talks about your team composition and their training. It's actually, those 2 things, composition and training, are NCP standards, so it's a very good metric. It says something important about your program. So where do you go to get the data that you need to use that metric? Well, it's really just a matter of going to your human resources records. The burden is borne by administrative leaders. It's a very modest burden. So this metric, if you're thinking about feasibility, is quite feasible. And if it fits into your portfolio, it shouldn't really be much of a burden on anybody to use it. Then that's the process metric, percentage of visits for patients age 18 years and older, with documentation of a pain assessment using a standardized tool on each visit, and documentation of a follow-up plan when pain is present. So this talks about the processes that you have in place for assessing and managing pain. So this metric is really a little bit more involved to use. It's super important. Some would say it's more important than the structure metric that we just talked about, but it's also more difficult to gather the data that's needed to use it. So the burden, who bears the burden here? Well, the clinical team. They're going to have to document the work they do in assessing pain and document what the findings were and document the care plan if that pain was severe. You would hope that that's part of what they do anyway, so maybe it's not much of an additional burden. It might just have to do with where they do that documentation. And then there's the issue of how do you extract that information about what happened with pain assessments and the follow-up plan. If you have a nimble EHR, then it might just be a matter of working with your IT staff to figure out where those data are within your clinical data warehouse and writing the algorithms and then pulling that data out. So you'd have some upfront effort, but in the long run, it really wouldn't be that bad to maintain. If you don't have a nimble electronic health record, if you can't extract this data electronically, then there would be really a very large burden on administrative staff who would be expected to do manual chart with you to pull this data out. And even if you're doing that for only a subset of your patients, that is an enormous burden and has huge feasibility implications. So that might tell you something about if this would be a good metric for you. Here, the burden may well outweigh the benefits of using it. So one more example, and this would be an outcome metric, results of the family evaluation of palliative care. So that's a follow-on survey that's sent to bereaved families. And an item from that might be proportion of patients who experienced anxiety or sadness while receiving palliative care who received too much or too little help. So you'd be looking at a satisfaction outcome as reported by family. So where do you get the data? Well, you'd have to administer a survey. And what's the burden there? Well, there's a burden on the family. They'd have to complete the survey, and hopefully they wouldn't mind doing that. It shouldn't be a huge burden on them. But then there's also a burden on the administrative staff and on analytic staff. Administrative staff for administering the survey, either telephonically or through the mail, and then analytic staff for having to collate those findings. So you can see the idea is to think about this is a metric. This is why I think the metric in itself is important, and then thinking back to the data that are required to use the metric, and then is the burden that's associated with gathering those data and analyzing those data bearable for your program and your program staff. Now, the next issue has to do with accessibility, sort of beyond the level of burden, really thinking about which data are available to you. And here, I like to think of this as a lesson that we see in everyday life. It actually plays out within many, many households all across the globe, I think. I call it lesson from lunch. So here you have, it's getting around noon, and the child is starting to feel hungry, and they ask the parent, what's for lunch? And the parent proclaims, cheese sandwiches. And the child reflects on that and then says, I don't want a cheese sandwich. Why do we have to have cheese sandwiches? I want tofu cubes, carrots, and a sliced apple. And for any of you who don't live in Marin like I do, and your children ask for different things, you might hear, I want a corn dog. And so the parent takes that in, and then realizing that there's more to what you get than just preferences, replies, that sounds good, but we don't have the ingredients for that. We have cheese and bread, so we are having cheese sandwiches. So that lesson there, that sort of global lesson, which also applies to developing a feasible portfolio of metrics for your palliative care service, is that what you get is dictated by what's on hand or what someone is willing to procure. So you really need to think about what data do you have access to when you're thinking about which metrics belong in your portfolio. So let's think about some items that you might want to include, and then think about the data ingredients that are necessary, and that will help to illuminate this issue of data accessibility. So if you think of a preferred metrics meal, so the dish on the first row, evidence of a management plan for all patients that screen positive for moderate or severe pain. So here you need chart data. You need results of pain screening and documentation of pain management plan. So if you have access to that, if you have electronic access to that, you may well have the ingredients easily on hand to use that metric. If you don't, then that metric might not be right for you. The next one, rate of administering chemotherapy in the last 14 days of life. So which data do you need for that? You need date of death, and you also need inpatient and outpatient diagnosis, procedure, and CPT codes. So here's an example of you need to have access to date of death, that data ingredient, in order to use that metric. And then you also need to have access to some administrative data as well, describing care delivered across multiple settings. And then finally, family satisfaction with information sharing and communication. If you want to use that metric, if that's part of the metrics meal that you want to be having, you need to have access to survey responses, which means that you need to be able to administer a survey to families. So keep in mind burden and accessibility as you're thinking about which metrics to include in your portfolio. And so then, as you've thought of what are the best practices in palliative care, What do your stakeholders care about? Which potential structure, process, and outcome metrics are out there that you might use? And then what are the data feasibility issues that you need to face? What are the data burden issues and what are the accessibility issues? At that point, you're ready to make your choices. And the number and type of metrics that wind up in your portfolio will be dictated by the developmental stage of your program. And here it really pays to think crawl, walk, run. You know, you won't start by measuring everything possible, or really maybe everything that you would want to measure. You start slow and then you build from there. Also, in addition to the developmental stage of your program, you would obviously need to think about the resources at your disposal to gather and analyze data. And as Brian, Cassel, and I have thought about this, we've really thought about this along a continuum, going from feasible minimal measuring, which is what you would try for if you're a new program or you have relatively few resources at your disposal, all the way to maximal measuring, which is great for established programs, for large programs, for entities that have lots of resources available for collecting and analyzing data. And most programs, would be sitting somewhere between minimal and maximal. They'll be somewhere along that continuum. So what does that mean in terms of number and types of metrics? Well, target minimal measuring. So you're a new program, you maybe have few resources available to you. Here, what we would recommend is that for each of those 8 domains as defined by the NCP, so structures and processes of care, physical aspects of care, and so on, for each of those 8 domains, you would have one structure or one process metric for each, including at least 2 process metrics. And what that means is that if you're doing minimal measuring, you could have as many as 6 structure metrics, which really carry minimal burden to gather the needed information for. So this is a nice approach if you don't have a lot of resources available to you. In addition to the structure or process metric for each of the 8 domains, you'd want to have 4 to 6 outcome metrics addressing those 3 types that we talked about. So clinical or patient-reported outcomes, social outcomes, cost and utilization outcomes. And so for the sort of core components of a minimal measuring portfolio, you'd have 12 to 14 items addressing quality, plus however many operational metrics you need, and you'd negotiate these with your stakeholders to describe the amount and type of service that you're delivering to patients, really the sorts of businessy things that you need to talk about. This is the amount of service that you're providing. So that's minimal measurement. And target maximal measuring. So if you have a more well-established program, if you have a lot of resources available to you, here you would want to aim for at least one structure and at least one process metric for each of the 8 domains. You could certainly do more than that if you want to, but that would be a good minimal goal for maximal measuring. And then you'd supplement that with at least 8 metrics addressing the three types of outcomes. And here you'd want to have at least 2 that address clinical or patient-reported outcomes. And then, just as you would with minimal measuring, you'd have as many operational metrics that describe sort of the amount and type of service that you're delivering as you would need to satisfy the needs of your stakeholders. So that's minimal measuring to maximal measuring. So we've talked about a framework for identifying your metrics, those 5 steps. And we talked about some targets for the number and type of metrics that you might want to include in your portfolio. And but before I go on to that, this is an example of what you could develop from a minimal measuring approach. So this is just some sample metrics using a minimal measurement approach. And just by here, sort of an example of beginning with the end in mind, being able to include on one page a set of information that describes your program, what it does, and outcomes of interest for patients and for families and on cost and utilization that all sits on one page that really, even though it's only 12 items, says quite a bit about what you do and how well you do it and how well your program is aligned with best practices. And it's the type of information, really, that just about any program could gather. So here, if you look at these designations, the S's are structure metrics, the P's are process metrics, the O's are outcome metrics. So you have, 4 process measures, 4 outcome measures, and the rest structure measures. So you can really see that the data burden is not that great. Really, anybody would have the capacity to pull together the information needed to make these types of statements, and it's really a powerful gathering of information about your program. You talk about your team, the training that it has, accessibility, what you do to address physical symptoms, what you do to help patients and families with coping, so addressing those psychiatric and psychological and emotional aspects of care. You talk about social supports and how you integrate with the services available outside your program. You can really say a lot with just a small number of metrics with a reasonable data collection burden. And that being said, even though this is, it seems straightforward and the end product is not overwhelming, even so, it's not easy to do. And the big reason why we can run into difficulty with this is that there's just really so many metrics to choose from, and there's really relatively little guidance on which ones to use. And also, when you're thinking about creating a balanced portfolio, when you want to have structure and process and outcome metrics, you need to think about the 8 domains, you need to think about the 3 different types of outcome metrics that are possible, and you need to think about accessibility issues and so on. There's just multiple factors that you have to keep in mind simultaneously, and it can be kind of overwhelming. And so to try to help with this, we developed this tool, the Palliative Care Measure Menu, and it's developed with support from the California Healthcare Foundation. And what this is, it's a compilation of metrics that allow you to speak to the quality of a specialty palliative care service, but the metrics are also really useful for speaking to the quality of palliative and end-of-life care delivered to a population of patients. So you could talk about the quality of care delivered to every patient with cancer taken care of by your health system, or every patient admitted to the hospital, specialty and generalist palliative care. But before we pop over to the web to take the tool for a test drive, I just want to tell you a little bit about it before we leave the slides. Currently, what's inside of the menu is 299 metrics derived from 19 different sources. And what we have inside the tool is information about each metric. So the data that are required to use it, the metric type, so is it structure, process, or outcome, the NCP guideline that it addresses, who developed it, what are the settings that it was used or tested in, and does it have any important endorsements, for example, from the NQF, or was it measuring what matters recommended? And the idea here is that you can use the tool to select 4 of the types of metrics that are appropriate for your setting and your service, and to exclude from consideration metrics that are unimportant to you or that are not feasible. So you can really trim down the number of candidate metrics that you have to consider overall, and then at any one time by using this information that we've provided about each possible metric. And inside the tool is a combination of quality indicators and metrics, and just to avoid confusion, I'll tell you what that means for those of you who are not familiar with these terms. So an indicator, a quality indicator, here's an example of that. If a vulnerable elder with end-stage metastatic cancer is treated with opiates for pain, then the medical record should document a plan for management of worsening or emergent pain. An indicator is really a statement of this is what good practice looks like. A metric gives more guidance on how to measure how often best practice is happening. So an example of a metric would be of patients reporting dyspnea at admission, the proportion with dyspnea relieved or reduced, score of 3 or less on a 0 to 10 scale within 48 hours of admission. So a metric will give you more information about how to compute the extent to which you're adhering to quality. A quality indicator is really more of a statement. If a measure set that was used as a source presented quality indicators, then that's what wound up in the menu. If a measure set that was used as a source for the menu reported metrics, that's what we put into the menu. We didn't modify them from their original form. And then about the 19 sources, many of them were identified in reviews by Arif Kamal and the Daru paper as well, and I'll show you where in the menu those references are listed. They came from, many of the structure metrics come right from the NCP guidelines or from the NQF preferred practices for palliative care. There are metrics that were developed by accrediting organizations or used by accrediting organizations like CMS, the NCQA, and the Joint Commission. There's measure sets that were developed by professional and academic groups, so the American Society of Clinical Oncology, their Quality Oncology Practice Initiative metrics. RAND developed some. We also took metrics from the Dartmouth Atlas, since that's such an important benchmarking tool. It's available to all of us. And then there's some metrics that are sourced as common use. And what those are metrics that either Brian or I knew to be in use by palliative care programs, which aren't associated with any one of the measure sets. They're very commonly these operational metrics that you use to describe the amount and type and timing of service that you're delivering, items that you report to your health system or your payer partners. We figure that since most groups need to use those types of metrics, even though they weren't part of the formal measure set, we went ahead and included them in the menu. And then I would note that metrics, some of the metrics are included in multiple measure sets, so lots of groups were interested in, for example, administration of chemotherapy in the last 14 days of life. In those instances, we only included the metric once and then just picked one of the sources to associate it with. So right before we go to the web to look at the tool, just the 10 steps of using the menu, or one way of using the menu. You begin by selecting the setting or scope for your portfolio. So you're looking for metrics for your community-based palliative care program, or your inpatient palliative care program, or you're looking for metrics that apply to everyone cared for your system, or all members in a health plan, or so on. So you select the setting and the scope. You verify which data are available to you, so you get at that issue of what's possible to collect given the data that you have access to. And then you select the focus and type of metrics that you want to consider either overall or one at a time. So you could, for example, go through and pick metrics that speak to each of the 8 domains sequentially to limit the number that you have to consider at any one point in time. You can select by focus area. So first I'm going to look at structure metrics, and then I'll look at process metrics, and then I'll look at outcome metrics. Or you could just consider the operational metrics that you need to put in play for your customers. You then apply filters related to the sources and endorsements, and then you review the metrics that meet your specified criteria. You have the option of learning more about the NTP guideline that a metric speaks to. You have the option of learning more about the source of the metrics. You can then save items that are potentially of interest to you that you might be included in your final portfolio. You can export those items to your computer, and then you can use that export file to support the collaborative process of selecting a balanced, feasible portfolio. So that's the how-to. Now let's do the fun part and go play with the tool itself. Okay, so here it is. Now, this is the beta version of the tool. It will eventually live on the CHCF website, so it'll have the beautiful CHCF banner above it, a little bit of introductory text. But embedded in that page, about a third of the way down, will be this tool itself, and it will function just as you're seeing it here. So as we talked about, your first level of demarcation is picking the scope and the setting that you want to select metrics for, and you do that through these tabs on top. So community-based palliative care service metrics, population of patient metrics, inpatient service metrics, hospital or hospital unit metrics. And you'll see that as you move around these, if you go down, so these are the community-based palliative care service metrics, you'll see that without limiting any output by filters, there's 180 metrics that are available to you. Once you identify the scope and the group that you want to hit metrics for, you can then get into the business of indicating which data you have access to. So you'll select the types of data that are or could be available to you for tracking metrics. So do you have information about date of death? And for each of these items, there's a little infographic that tells you a little more about what we mean by those variables. Do you have access to date of death data? And here, it's date of death regardless of location. If you're part of the health system, you probably know which patients die in the hospital, but do you know generally when patients die? So you can look at outcomes for patients who die elsewhere. If you don't have access to those data, and if you don't, you should send me an email because I can tell you how to get it. You just uncheck that box, and then you'll notice if you go down that the number of available metrics went from 180 to 125. So what's happening is by indicating the variables that you have access to, you'll trim down the metrics that are presented to you as being possible, as being ones that you might use based upon the data that you have available to you. So let's say you don't have access to date of death, you don't have access to information about who's using hospice. You know who's, for example, discharged from your hospital to hospice, but you don't know about other types of hospice use, so you uncheck that item. The next step is that you can apply filters that have to do with focus and type. So here is where you see the information about metrics that speak, structure and process metrics that speak to each of the 8 NCP domains, metrics that speak to the 3 outcome focus areas, and then your operational metrics. And the default is to select them all, but we can go through and say, actually, we really just want to start by looking at metrics that speak to physical aspects of care, spiritual aspects of care, and cultural aspects of care. So that'll trim your list down further. Now you're down to 36 possible metrics. You can also select for metric type, structure, process, and outcome. And then you can also select for endorsements. So you could say, I only want to see metrics that have been NQF endorsed, or if they're not NQF endorsed, those that were adapted, those that are quite similar to an NQF endorsed metric, but that are perhaps slightly different. You could also make a selection and say, I only want to see those that were measuring what matters recommended, or those that are very similar to those. Or you could also select by metric source. Now here you can see these are shortened names. They're sort of nicknames for the different metric sources. And if you're not sure about what those are, like, oh my goodness, what is this ACO thing? You could either just, you could select all of those, excuse me, so you could select all of those. And then if you want more information about the metric sources, that's up here in the resources section. So up here in resources, you'll see instructions, and that's just a general review of how to use the tool, how to use the filters. And then there's also information on each of the sources. So you can come here, there's the 2 review articles that I mentioned to you, and we saw, the ACO metrics. Well, here there's information about what the ACO metrics are, some notes about how those were developed and how they're used, the original settings that they were used in. If available, we've included a pertinent reference that talks about the process of developing them or using them. And then also as available, there's links to, for example, a program page that describes the ACO initiative, or a link to how to get to a tool. And all of the possible sources are listed here in this menu that's at the top of the page, and so you can jump to a source that's of interest. So coming back over to the filter page, you could select for a particular source or just see all the metrics that meet these criteria no matter the source. And then once you're comfortable with your filters, you just click this button, Show Me Results, and it shows you that 36 metrics that met the criteria that you specified were found. And here in the results sections, it shows you the domains, so which of the NCP domains the metric addresses, or which type of outcome metric it is. So here these are the physical aspects of care, social aspects of care, et cetera. It tells you the metric type, so structure, process, or outcome. And these actually are all sortable, so you can sort alphabetically there. The metric source, so which measure set did it come from? Here we have some piece metrics, some ACO metrics, et cetera. The original population, so this is the population of the metric that was used when the metric was first developed or tested. And there's a few of these. Sometimes these are developed specifically for palliative care patients. Sometimes they were developed for a specific disease group, like cancer patients. We included this information because we thought it was important for you to know about, but you should be aware that some metrics that were developed, for example, originally for cancer patients would be perfectly appropriate for other populations. Some metrics that were developed to assess quality of care delivered to an entire population of patients may be perfectly appropriate for assessing the quality of care delivered by a palliative care service, and then vice versa as well. So original population is informative, but I'd encourage you not to think of it as being restrictive. Then the next item that's included in the results page is the NCP reference. So this is the specific NCP guideline or guideline criteria that the metric speaks to. And so here you see for this top one, for physical aspects of care, the metric for of patients on opioids for whom a BAL regimen is ordered, that speaks to NCP guideline 2.1. And if you want to find out what NCP guideline 2.1 is, you just come over to the resources page, and then you go to NCP guideline 2.1, and it shows you, there's the text of the guideline, the supporting criteria, and it reminds you of the domain of care that's being addressed. So you can make that link between best practices and the metric that you're considering using, and that can be important for you, and it can also be important for your stakeholders as you try to educate people about why a particular metric would be useful for your program. And then as you've identified metrics that meet your needs, you'll see over here in the Add column, you can select one that you want to add to your My Metric cart. So here, just add a random sample of these, and you'll see that the My Metrics number increases with each one that you add. You then come here, and this shows you which ones that you identify. It tells you the domains that they address, the type. We have mostly structure and one process metric here, the source, the original population, and so on. You can say, wait a minute, I don't care about that one, I want to get rid of it. And then when you're happy with your selections, you can export that to your computer. And it comes out as a fully functioning Excel spreadsheet. So here you'll see the metric ID, that's just a way for you to keep track of them, the domain, the metric type, the source, the original population. If it was NQF endorsed, it will give you the NQF number. If it was measuring what matters, recommended, it will be indicated there. And then there's some columns there for you to make notes in. So scope setting, notes. This is a fully functioning worksheet, so if you don't like that, you can change it to stakeholder, interested, and then add the value to this is one that's particularly interesting to the CEO, or use it however you want. You change the font, the columns, whatever it is that's included there. So that you can use you can use that tool to support the process of bringing potential metrics back to your stakeholders and then having a conversation about which of these are right for us. So that's the basics of the tool. You have, when you're done looking at your results, you can go back to the filters. If you want to start over, you can reset all of them. If you need to empty your cart, you can do that in your My Metrics cart. You just do that by pulling it up and then removing all of the metrics inside of it. And then you have the option of creating different measure sets for each of the 4 designated populations. So let me go back to the slides for one moment. Yeah. So just a few more notes. I'm going to jump ahead here. I had some screenshots in case we ran into a web catastrophe. So that's the functioning of the tool. I think it's pretty intuitive, and I think if you go in and start playing with it, you'll get the hang of it relatively quickly. You're welcome to use it now as it lives on the beta site and giving you the URL there. And soon, as I said, it will live in the tools section of the CHCF Community-Based Palliative Care Resource Center, and I've given you the URL for that. We just have to go through the full PubCom process here at CHCF, and I expect that that will take a few weeks. Also, I wanted to tell you, if you want to learn more about metrics and measurement in palliative care generally, Brian and I have developed a course that's available through the Cal State University Institute for Palliative Care, Metrics and Measurement for Palliative Care. It's 4 hours online, self-paced. It's a really painless and convenient way to take in a lot of information about, how to apply and adapt well-known measurement frameworks that are used in healthcare to palliative care specifically. We'll go in more detail over the 5 steps for choosing metrics. We include a little half-hour tutorial on how to use the palliative care measure menu, and we also offer some tips for being successful and avoiding mistakes. So if you're interested in that course, so let's say you have a new quality analyst who's assigned to your program, you want to give them a primer on palliative care metrics and measurement, the URL for the course is listed there. Also, I want to take a moment to do some acknowledgements. I'd like to acknowledge the co-developers of the menu concept and the content and the wonderful web tool, Brian Cassel, my colleague from VCU, Lewis Broome and the amazing team at his IT team, who really took what was a big, cumbersome, but interesting Excel spreadsheet and turned it into a very usable tool. The organizations that have supported our work, the California Healthcare Foundation, the Coalition for Compassionate Care of California, the CSU Institute for Palliative Care, the National Hospice and Palliative Care Organization. We also want to do a shout out to all of you who have shared your stories and data and expertise with us through the years, and then a special shout out to those of you who took a look at the original Excel-based tool and really planted the seed and helped us to appreciate how much we needed to have a more functional web-based version of this to maximize use. So that's it for me, and I just want to say before we take some questions, please do be in touch if the tool gives you any trouble, or if you know of a metric that you think might be a nice addition to the menu. Happy to entertain that and look at it. It's easy to maintain the tool and to add items to it, so we'd welcome your input in that area. And so with that, I think I'll hand it over to Kate to help with facilitating any questions that you might have.
Hi, everyone. Thank you, Kathleen. This is Kate Myers, and it looks like I see Leah Morris from the Coalition for Compassionate Care of California has raised her hand, so I'm going to try to unmute you, Leah. Let's see if I can do that. I might need to do it from yours. Hold on one sec.
Can you hear me?
Leah, you should be unmuted. Yep, go ahead.
Oh, sorry. I thought I just typed a question in. I just was wondering about the webinar being recorded and available for additional people to listen to.
Yes,
and also,
we have recorded it, and we're going to be sending out a link to the recording as well as a PDF of the slides within a couple days. It takes WebEx a little bit to get the recording out.
Perfect, beautiful. And then the tool eventually is housed on the Healthcare Foundation website?
Yeah, it will be. If you look at the URL that's on the slide, you're welcome to go and use it now on the beta site. But eventually, it's going to live in the Community-Based Palliative Care Resource Center, which is on the CHCF main website.
Beautiful. Thank you.
All right. Thank you, Leah. And it looks like we had another question, hand raised, I think, from Mary Golden. So I'm going to unmute you, Mary. Go ahead. Mary Golden from Lightbridge Medical Associates. All right, something may not be working there, so if you want to type your question in, Mary, if you're still on the line, we can see if we can see it in the Q&A box. And let's check out the Q&A box. Okay, the same question. Got it. Yes, we will be sending out the PowerPoint. Are there any other questions, either by raised hand or Q&A box? We'll give you a moment to type those in if you need to, or to raise your hand. All right, it looks like we have Karen Van Ziel, which unfortunately, Karen, I think you might have dialed in separately from logging into the WebEx, and so we can't actually tell which phone line is yours to unmute you. So if you could type your question into the Q&A box, we'll give you a couple moments to do that, Karen, because we unfortunately can't identify which line is yours to unmute it. We'll give you a minute, and anyone else who wants to either raise a hand or type in a question. While we wait, any other final words of wisdom?
No. Feel free to communicate as you play with the tool. You're welcome to use it. Just pop over to the development site. It'll be fully functional there. If anything gives you any trouble, or if you really like it, or if you think of different ways to use it, share. We've had a lot of folks express a lot of interest in this, and we've put a lot of work into it, and if there's a way that we can make it more useful to you, we're happy to do that.
All right, great. We do have Karen's question here. If we can.
Is there a distinction between established program and well-resourced? We feel established but not particularly well-resourced. Yeah, Karen, I know. You're in that particular situation of being in a safety net setting. So you guys have a well-established palliative care program, been doing amazing work there for many, many years. But yeah, you guys are pretty lean. You're asked to function with relatively little infrastructure. So I would encourage you to use more of a minimal measurement approach. So think about what can you say that really speaks to the quality of your program simply by listing your structures, and then pick a few really telling process metrics and a few really important outcome metrics, ones that are feasible for you to gather, and start from there. You're absolutely right. Those two things are not necessarily the same thing.
All right. If there are any more questions, go ahead and either raise your hand if you dialed in through the WebEx system, or type into the Q&A box. We have just another couple of minutes left.
You're welcome, Karen. Good luck to you. Let me know if let me know what your portfolio is when you get it selected. Okay, we have a few people on the line. I'd like to invite all of you who think this is like the coolest little tool you've ever seen to put an exclamation in the chat box so that we can see all of your smiling faces, even though we can't see your smiling faces.
Okay, it looks like we have one. Oh, no, those were comments that came through, not questions. A lot of good thanks and accolades.
Excellent, yeah, so everybody likes it. Good, all right. Okay, there's a little more coming down the road. We have some...
No, they're writing.
There's some coming attractions, which we'll be sure to fill you in on. There's a companion tool that goes with the measure menu. It's called Palliative Care Inputs and Outputs, and it's also a web-based tool that uses categorizes information and uses filters that will allow you to quickly identify reported outcomes for different types of palliative care programs operating in different settings and serving different types of patients. So that tool, for example, you can go in and say, okay, I'm looking to create a clinic-based program that's operating in an academic center, and we're going to be serving cancer patients. What are the different types of outcomes that similar programs have reported, either in the published literature or through posters at conferences and the like? And this tool will let you access that type of information quickly. And we know that that's really important information for those of you who are, say, putting together program proposals or planning for expansion or trying to articulate to folks who maybe don't know quite so much about palliative care what the possible impacts are. So that one will be coming up within, I think, about 8 to 10 weeks is my guess on that one, and we'll be sure to get the word out to you on that as well. And so with that, let me make sure there's no questions besides all of your exclamation points. Thank you. Awesome. Oh, good. Okay. All right. You guys like it. Good. Didn't want to build it and nobody liked it. So thanks for your time. Thanks for your interest. Go forth and use the webinar in good health, and best wishes to you as you relieve suffering and stamp out disease, and look forward to talking to you again sometime soon.
Thanks, everyone.